Good morning, everyone. I hope everyone's having a good dry day. I certainly enjoyed being able to drive in this morning without the rain, although I know we need it. And everyone's ready for our conference today. I'm very excited about today because we have a very diverse group of topics and speakers, and it's going to be very interesting. And I hope that everyone enjoys it as much as they did yesterday or more. Uh, so with that being said, we'll go to slide 2 next. So we want to take a chance to thank all our sponsors. We have 2 platinum sponsors, Technion and SG2. Quadramed is our silver sponsor. We have posted banners on the left-hand side of your screen. You will see their banners. There's a way to click and go click to see more. And when you do that, we're monitoring, we're able to track that. And so if you click on all 3 banners and go check out our sponsors' websites, you get put into a raffle for an Echo Dot. So please be sure to do that. Next slide. Technion is one of our platinum sponsors, and we have been working with them for several years now, and they're a great group for helping with our data warehouse. And they helped us move to the cloud, and so we're really proud to have them as a sponsor. Next. SG2 is our second platinum sponsor, and they are a new partner that we have started working with. They acquired what was previously known as Intellier, which everyone might be familiar with if you're working in data submissions, and we've been working with that partnership for quite a while. And now we'll be working with SG2, and we're proud to have them as a sponsor too. And as part of this, we're going to show you a couple of videos for their sponsorship. Kevin? Great, thank you, Kevin. And we also want to recognize Quadramed, our silver sponsor. As many of you know, we've been working with Quadramed for more than 10 years, probably almost 15 years, and they manage our master patient index. So thank you so much, Quadramed, for being a sponsor. Our next slide is our planning committee, and I want a special thank you to all our planning committee for volunteering time to help put this together. And if you work with them, make sure you give them a pat on the back for all their hard work. And a special thanks to Kevin, my technical support here, and for helping run the show. Posters. So I'm learning this platform probably the same as you are. And yesterday we have the link where you can go out to our website and get on to look at the posters. But we've also now added them to the Remo platform. So during the break and also after the networking at the end, you can actually just click directly on the posters to the right-hand side of the screen when we're in the lobby mode. So you can go take a look at what's going on the posters, and then make sure you take the survey if you want to be entered in the raffle, so that we can do that at the end of the event. So we'll leave it open for a little bit today, and then we'll close it and do the survey, do the raffle probably at the end of the day or tomorrow. Next slide. This is a certified CNE and HIM-CE, so you need to attend both sessions in order to get your CNEs. Evaluations will open today. After the event, we'll send out the link, and then you have till November 19th to take the survey, and then it'll take us 1 to 2 weeks to get your CNE and CEs certifications out to you. Next slide. And at this time, we have no conflict of interest with any of our speakers. With that being said, I think we're ready to get started. So at this time, I would like to invite Mike Sanborn onto the stage. And he will be our first speaker today. And another person I've known for a long time, Mike has served on our INFIC committee. He currently serves as a board member for the Dallas-Fort Worth Hospital Council. And he is an avid user of the data. He currently serves as the CEO of Baylor Scott and White All Saints Medical Center in Fort Worth. And All Saints is a regional referral center with comprehensive services. And he also came from not pharmacy, cardiac surgery and all that. We first started working with Mike when he served on our committees. Then he helped set up a new adventure with the TQI and cardiac surgeons. And he's just been a really great supporter of the foundation, and we're very proud to have him come and give a perspective of a CEO's needs when it comes to data analytics. So I'm really excited to have him present today, and I turn it over to Mike.
Thank you, Teresa. I appreciate it, and look forward to having a brief conversation with everybody today. And I too am somewhat new to this format, but have practiced a little bit, and hopefully everything will go well. As Teresa said, I'm the president at Baylor Scott and White All Saints Medical Center in Fort Worth. She was actually right. I am a pharmacist by background, but was kind of in charge of the pharmacy enterprise for the system for a couple of years, but then moved into cardiac services for the system, and then have served as the president of 2 different hospitals for our system, and been here at All Saints now for a little bit over 5 years. So my goal really, and I'll kind of walk through, share my screen here. My goal is really to give you an idea from at least my perspective, what's important, what's not, and try to be as general as I possibly can as it relates to some things. And certainly the only modifier I would say is that everything that's important to me may not be important to the CEO at your facility, but or your organization in general, wherever you work. But I do think hopefully the majority of this presentation will be applicable regardless of the folks that you're providing data for. So really kind of cover what's important and what not. This slide just kind of gives you, as far as bubble size, where I kind of plan to fit everything. So I'll give you a little bit of my perspective, because I think it's important to understand where I'm coming from as it relates to the needs that I have from a data perspective, and then go into some metrics that matter. And I think these will apply to the vast majority of hospital presidents, certainly, and most facility leaders that may need data. And then talk a little bit about what's not important, or at least things that I don't think are very important or are frustrating for me in the world of data. And then finish up by just talking about just some general tips for success. So hopefully that last slide will really just kind of encompass my whole presentation. And regardless of whether you're paying attention through the whole thing or not, it'll be hopefully a good summary of everything. So my formal objectives are listed here, and I think I've mostly covered those, but just as an FYI, those are the general perspectives. And throughout, I'll give some examples, and certainly happy to answer any questions that you might have related to some of the subject matter that we talk about. So hopefully most of you are familiar with the fact that Fort Worth is a little bit different. I had spent a lot of time in Fort Worth, in and out of the city, but prior to coming here to serve as the hospital president, didn't really realize the magnitude of the medical district. And I put this here because, our hospital is in blue there on the left, the lower left, but a block away from us, I can see all these hospitals from our windows. Medical City is just north of us, and across the street from them is Cook Children's Hospital. Across the street from them is Harris Methodist, the flagship THR hospital, and then over to the right and just a little bit to the south, east of our hospital, is JPS. And throughout this area, tons of physicians' offices, imaging centers, urgent care, you name it. So this truly is a real medical district. The analogy or the similar area is Houston, if you spent any time there. And that creates some interesting dynamics, I think, that I'll touch on, and makes, to some extent, some of the things we're doing here a little bit different than what might happen if you were a standalone hospital in a particular city or whatever. You know, we've had some flexibility here and certainly some challenges as it relates to the medical district. These are just some general statistics for our facility. I'm not going to go into much detail as it relates to that. We are a level 3 trauma center. The level 1 trauma center in Fort Worth is JPS, licensed for 538 beds. I think Teresa mentioned that. We deliver a lot of babies. We have the largest NICU and birthing program in Tarrant County by far, and the second largest in all of DFW, second only to Parkland. But when you look at our kind of key service lines, and this is intentional, several years ago, we really kind of decided that there was a better way to go about healthcare delivery from our perspective as it relates to what the needs were of the community that we served. So we really focus on these 4 areas. So women's health, cardiovascular and thoracic surgery, transplant. Primarily, we do liver, kidney, and kidney pancreas. It's the only liver transplant program in Tarrant County. And then oncology. And a big part of our oncology program is the largest head and neck cancer program in the state and one of the largest in the United States. We train a lot of fellows here for head and neck cancer surgery. And so that's a big part of what we do. Unfortunately, it's one of the fastest growing types of cancer in the United States. And I think our goal here is a little bit different than a lot of facilities. And I'll reference this in one of the examples that I talk about. Is our goal is to really be exceptional in these 4 areas, and more importantly, comprehensive. It was very clear to me when I got here, primarily from looking at the DFW Hospital Council data, that a lot of patients traveled outside of the Fort Worth area for complex care in these 4 service lines. And so they were either going to Dallas or Houston or even further sometimes to get care in a lot of these areas. And so we've really tried to focus on doing things that aren't necessarily competing with the other local hospitals in town, but are adding to the services that are available in Fort Worth. And there's, probably 20 firsts that we've had in Tarrant County since our focus has been there. Most recently, we did the first left ventricular device implant in Tarrant County back in July, and have many more of those scheduled, because if you needed an LVAD prior to a couple of months ago in Tarrant County, you had to go somewhere else in order to get it. So that's just a little bit about the hospital, just to give you kind of a perspective. But now let's dive into really what's important from a dashboard perspective. So there are lots of dashboard styles out there, lots of templates out there. I'm not going to get too much into that. I'm going to talk more about, for me at least, what's important as it relates to the content of the dashboard, because I think the way it's laid out can really change depending on what the needs are of the organization, and honestly, how much data you're putting on a particular dashboard. I've got dashboards that I'll show you that only have a few elements, and other dashboards that are much more complicated might have 15 or 16 different elements that we're monitoring. So one of the things that's super important to me is quality and safety data. And I'll talk a little bit about each of these in depth as far as some of the more important elements that I look at. But I think this is going to be true for any hospital president. These are, in many cases, publicly reported measures. So we're out there from a report card perspective. They drive a lot of the rating programs. There's probably 30 different rating organizations that are out there, everything from US News and World Reports to Leapfrog and everything else. And so this particular set of metrics is very, very important to consider from a dashboard perspective. Another big one for us that has certainly been critical as it relates to the pandemic that we've been through, and has been a challenge for virtually every hospital and healthcare organization in the United States of late is related to human resources. And so I'll talk a little bit about some of the elements that we monitor and that are important to us as it relates to HR, but really, really important for me to have my finger on the pulse of what is going on as it relates to human resource activity. Obviously, COVID-19, there's some great tools that have been developed in the database that I think are really cool and easy to use as it relates to this pandemic. And certainly from my perspective, if you would have told me 2 years ago that something was coming that was going to dictate all of the other services that we provide in the hospital from time to time, I would have just laughed and said, yeah, don't believe you. But that's exactly what's happened. And what has been amazing to me is that, especially in the waves that we've had, 3 official now, some people say 4, but I've felt 3. The waves that we've had have really dictated and in some cases limited the services that we've been able to provide to non-COVID patients. And that is just an incredibly difficult challenge that virtually every hospital administrator has had to manage. So these COVID metrics can be very important as well. In-house statistics, tons of those. And I'll talk about really some of the more important ones that I love to see on a regular basis, but those will be, they actually can differ from month to month. There's some that I only really kind of monitor every quarter, some only every year. But there's quite a few that we monitor every week, every month, or even every day, potentially, like central line infections. We want to know exactly when those happen, the day they happen, ideally, so we can do a root cause analysis to figure out what happens. So those roll-up numbers are really important. So we'll talk a little bit about those. Next is just general market trends. This is one of the things that I mine the database for pretty heavily, and I'll show you a very specific example of how this has helped our organization be successful. But I love to play around with the DFW Hospital Council database. Every quarter, I usually spend quite a few hours digging through the data to see how trends have changed for our hospital, how trends have changed overall in the various service lines. And I think Greg Shelton and so many others have been instrumental in just day after day after day, just improving that database to make it more user friendly for this kind of data. So I'll talk a little bit more about that. And then finally, physician behavior. Talk a little bit about that as well. But I can't imagine a president out there that would not find it valuable to know where their physicians are practicing, the types of procedures that they're doing, all kinds of other data that is out there as it relates to physician behavior. So we'll talk about that a little bit more in depth. Ultimately, I think if you're able through dashboards to keep your eye on these kind of 6 key areas, you can have a successful organization, but you need to be monitoring these 6 areas. So now let's dive a little bit into some of these as we go through. So in-house statistics, again, these are what are important for me. Certainly not an exhaustive list, but some of the high-level items that I think are really, really important that you ought to consider for a dashboard if you're developing dashboards related to in-house metrics. So volumes from various areas such as surgical volume, both inpatient and outpatient, radiology volume, both inpatient and outpatient, even various types of procedures, interventional radiology versus diagnostic imaging, for example, all very important metrics to be monitoring from time to time. Likewise, occupancy and capacity info. Our hospital is pretty much full every single day. There are very few days of the year where we don't have a lot of ED holds, but I need to know those numbers. I every 12 hours get a summary of capacity, vacancy by unit, that kind of thing. And that is one thing that I look at every single day, every single 12-hour period. It's important to us to understand what's going on. And That then leads to a lot of other downstream questions that can drive other metrics. Simple things like, what is the time it takes from the moment a bed becomes available to when housekeeping cleans it to when it can now be filled with a new patient that's waiting in the ED kind of thing. So lots and lots of those types of metrics are super important. Length of stay, like I mentioned, ED holds, on-time starts in the OR, very important. We also look at lost transfers. Generally, I look at those by the week. During COVID, our volume of lost transfers has soared astronomically. It used to be that we only lose about 10 or 20 a month. And now sometimes in a week, we'll lose 10 or 20 or 30 just because we do not have capacity. And a lot of the transfers, we're the only ECMO facility in Tarrant County. And so we get a lot of transfers related to ECMO care and more complex care. So all very important. Turnaround times in lots of different areas, lots of different places, all very important. And then of course, other individual metrics for individual areas, like left without being seen in the emergency department. Length of stay, I want to maybe go back to that because it's really, really important for, I think, most facilities to understand length of stay. We look at, and I think a lot of places do, look at observed versus expected length of stay. So the O to E ratio, we call it. So you always want your O to E ratio to be less than 1, meaning that your observed length of stay is lower than what is estimated. That is a great sign, not only of efficiency, but also of the effectiveness of your physician documentation. So we monitor that metric very, very closely and quite regularly. And so that's an important one for me to see on a regular basis. Lots and lots of expense metrics. I like to see them by individual department. I also like to see them by service lines. Can be very important, again, episodic, but certainly on a monthly basis, we'll look at all of these as they roll up. But from time to time, and especially during COVID, things like pharmacy metrics and the supply chain metrics have been very, very important because we're using a lot of drugs, a lot of supplies for our employees as well as for our patients that we were not using 2 years ago. Those have all become quite expensive due to problems in the supply chain. So monitoring those has been a little bit different over the last couple of years. And then, of course, overall financial performance metrics, again, by service line, also looking at inpatient versus outpatient volume to see if there are fluctuations there. But financial performance for any hospital is critical. So dashboards that can quickly tell me how we performed in the last given period, whether it be daily, weekly, monthly, or quarterly or annually, all very, very important. So those are some examples of in-house statistics that I think are important. The other one that may or may not be important, but I find it valuable, and I review this on a quarterly basis, is an analysis of our existing contracts, because we contract with a lot of vendors for a lot of different things. And based on performance against various contracts, and these contracts can be clinical for things like intraoperative monitoring and OR, all kinds of other clinical metrics, or they can be more as it relates to just contracted services that we have. For example, we use Aramark for our housekeeping services as well as for our food service. So looking at these can be very, very important. And then working with the vendors to make sure that they're meeting our needs can be very important. We've actually even recently made a change related to one of these. Typically, traditionally, in history, our hospital had contracted out for a service. We just brought it in-house a couple of months ago because we were just having a hard time getting reliable service from any contracted vendor. So this can be quite helpful. So here's an example. I've got 1,000 I could show you related to in-house statistics, but this is one that's a little bit different that I thought you might find interesting. We look at antibacterial utilization, and maybe it's my pharmacist background that makes this more interesting, but BD puts out a really good report that also provides both teaching hospital, non-teaching hospital performance, as well as regional performance related to antibiotic utilization, as well as a national antibiotic utilization performance. And so in each of these graphs, we're the orange line. And of course, you always generally want to be below the orange line because the line is measuring days of therapy per 1,000 days of antibiotic utilization opportunity. And so this generally gives you an estimate, a quick estimate of whether you're over prescribing antibiotics or not. So again, one of many possible metrics, but I like this one because any metric that has regional or comparative estimates at the national level or like facilities can be quite helpful, because a number in and of itself isn't always helpful. Certainly trended, it can be a little bit helpful, but when you're able to add in some comparative statistics with other facilities, that's always even more helpful. So now let's talk about HR, head count, labor expense per whatever. We use a metric called AED, which is adjusted discharge, and it basically levels out to some extent the impact of inpatient versus outpatient services much better than a case weight adjusted discharge. We converted to that metric a couple of years ago based on some of the huge fluctuations we were seeing in our dashboards at various hospitals that had fluctuating inpatient and ambulatory care. So all of these numbers are obviously important. Turnover of late especially has been really, really important to monitor. Are we going up? Are we going down? Are we flat? Are there particular types of positions where we're seeing a lot of turnover? Certainly in this market, we've seen some pretty significant increase to our frontline workers, especially minimum wage increases at a lot of the various local hospitals here. I'm sure that's probably true across the Metroplex. So that is really important. How long does it take for me to fill a job? That has definitely been extended through the pandemic. I'll show you what that looks like specifically for our hospital. We've got a really cool dashboard that is published every month related to that. Any labor expense trends are very, very important. One of the things we're monitoring now is our premium labor expense, because like virtually every hospital in the country, we're using, prior to the pandemic, we literally did not use agency at my hospital. We did not use agency for any position at our facility. That is no longer true. My bill last week for agency labor was $430,000. So that, and that's just for the premium on the labor, not for the labor itself. So our labor expense has gone through the roof from an agency perspective. I imagine over the next year or two that will hopefully die down, but that's a big important metric for us to monitor. Certainly employee experience and employee satisfaction, people monitor this in different ways. We have national benchmarks that we compare this to, which are very, very helpful. I get this data every 6 months, which is plenty. But more importantly, we act on this data during those 6-month periods based on the feedback that employees provide us. So this is an example of our dashboard that we use, and this is real data from last month. This is from September for me, for my hospital, but it gives you our total head count, which is essentially the total overall head count that we have. You can see the FTE is really small there. The way these graphics are, each of them has a trend line that gives you a general idea over the last several months how you're trending as it relates to each of the various metrics. So you can look at this. So if you go across 3 to terminations, we had 68 in the month of September. And that you can see that trend has kind of been upward. And then leader terminations, we had a little bit of a spike. There were 4 leaders that moved. We had one leader, though, I mean, these aren't all bad. We had one leader that took an awesome job in Phoenix. She got a really great opportunity to move up in the world. So we certainly promote that kind of turnover. Never want to see a leader leave unless they have to. But that was a great opportunity for her. So we certainly encourage that. I'm not going to go through every single one of these, but you can generally see the metrics that we monitor, and these are all color coded. And if it's dark blue, that means we're meeting the benchmark and our numbers are getting better. So our productivity is meeting the benchmark and getting better, as is our overall engagement score. But if it's light blue, we're meeting the benchmark, but we're not improving over prior months. So we have opportunity there. And then if it's yellow, we're not meeting the benchmark and we're not improving. So the yellow, to me, is really a big area of focus here. So this is an example of a dashboard that we have spent, oh my gosh, years refining, and gives me a lot of information in a glance. Very, very, very helpful. So now let's talk about quality and safety, because certainly a lot of metrics here that are important. I think most of these would apply to virtually any hospital. So readmissions, outcomes, mortality, all very important. We look at a lot of individual metrics in certain areas. For example, every month I look at Apache scores in our critical care areas. That is a great metric that is available, and it is risk adjusted and has national benchmarks. We also measure that internally and can look at internal benchmarks related to risk adjusted mortality in the ICU, that kind of thing. So we split it out by service lines. We split it out by individual physician. Lots of different ways you can look at readmissions and outcomes. So very, very important metric. All of the patient safety indicators, such as hospital-acquired conditions, various infections, falls, all those things, very important to the Joint Commission, very important to me. We certainly don't ever want to injure a patient because of something that we could have done better. So the better we can do related to this, the better care we're able to provide to the patients that we serve. All kinds of occurrence reporting. We use a system called MIDAS here. I think that's pretty common across a lot of hospitals in the United States. They've got, I know, well over 1,000 hospitals in their database. Very helpful system because it also provides comparative metrics for a lot of different things that we monitor. But this is a great way just for our employees, our physicians, anyone really, to document something that doesn't occur, that wasn't quite right. So this can be issues with timeouts in the OR. It can be physician behavior or employee behavior issues. It can be an outcome issue. It can be anything, literally, that an employee thinks is unusual that they need to document. Sometimes it's very specific patient information. So I like to get a summary of those reports, especially the higher level ones. And my risk manager generally sends me that summary on a weekly basis. And it's very, very helpful to kind of get a pulse on what odd things are going on in the hospital. Lots of external measures like pay for performance metrics, the CMS metrics, all of that. The state actually provides a pretty good summary of our estimated performance against a lot of these metrics, both at the Medicare and the Medicaid levels. And I look at those reports on a regular basis, and they're very helpful to see how we're trending. Anything related to patient experience and patient satisfaction, we've had a kind of a full court press on this through the pandemic, because like just about every hospital in the country, we saw a dip and we knew we could do better. And we're actually hitting all-time highs on patient experience despite the challenges that we've experienced related to the pandemic. We're in the top 20% of all hospitals in the United States. I think the top 16% to be specific. But I look at those metrics. We look at them every week. We get a summary on Friday that summarizes by unit who is performing, who's performing well. And then the individual, there's about 8 different breakout metrics that you can look at related to patient experience through HCAP scores to determine, are your physicians communicating well? If not, why not? Is your staff communicating well? Is your nursing communication going well? All these things are helpful to determine where we might be able to tackle some improvements. So here's an example, and this one is a little bit unique as it relates to quality, in that we did an analysis of, we have a community clinic here on our campus that sees unfunded patients, because in Tarrant County, we're very fortunate to have JPS here that sees a lot of unfunded. JPS by policy, though, does not see undocumented unfunded patients. And so a lot of those patients, if they're not at JPS, end up at other local hospitals and certainly ours. We created this clinic several years ago, and it has been incredibly successful. And we use data and this is an annual look that we do related to this. And you can see the numbers are actually quite large as far as patient volume here. But looking at preventable hospital visits by funding status of patients. Again, this is very specific to my hospital, but we spend millions of dollars on this clinic. And so it's helpful for me to know that we have had a pretty significant and long-term sustained impact on reducing hospitalizations and keeping this population healthy. So this is more of an outcome metric. We could look at and dig into very deeply what are some of the specific drivers of these individual metrics, but this tells me at a glance that we're doing very well in this patient population that has a lot of societal challenges as it relates to keeping them healthy. So really important. Now let's talk about physician behavior. This might be the one that some of you were waiting on, and it means a lot of different things. Sometimes it is actual behavior, and it kind of goes back to those Midas reports. Occasionally we'll have a physician that is not having a good day and will have a behavior problem. Occasionally we will get a Midas report for a physician that went unbelievably beyond the call of duty to provide, for example, some education on a particular unique patient situation to the nursing staff or something like that. So we can then recognize that physician. So sometimes it's actual the way that physicians behave on a day-to-day basis. Generally, though, it's other things. So the splitter data on the DFW Hospital Council database is fantastic and very, very helpful for me. And I never use this as a bludgeon. I'm one of those people that tends to look at the data a little bit more introspectively. If a physician is splitting between my hospital and say 3 others, which is not uncommon in Fort Worth because of a variety of different things, the first question I have, is there anything we could be doing better to meet the needs of that physician? Sometimes you'll find that it's equipment issues. It may be staff issues. It may be inavailability of block time in the OR. There's 1,000 different reasons why a physician might split. Sometimes it's things beyond the physician's control. It could be payer issues. We have a lot of specific contracts. There are a lot of Baylor contracts, for example. There are a lot of American Airlines and teachers, employees that have Baylor as an exclusive provider of insurance benefits. So they have to come here. So physicians have to bring those patients here. Otherwise, they get huge out-of-network expenses. So likewise, THR and Medical City, they all have those types of contracts as well. So sometimes it's necessary, but the splitter data can be very valuable. And again, can be an indicator of supply and equipment needs as it relates to things that we do, but also looking at the types of procedures that we provide, what is increasing, what is decreasing, can help us better understand if we need to invest more in certain areas. Robots are a perfect example. We just acquired another XI robot recently, as have a lot of local hospitals, because robotic surgery is increasing. So we monitor that particular metric, and that's a physician behavior metric that we monitor to see how many physicians are using robotics for surgery. All kinds of things related to clinic volumes. I look at on a monthly basis how long it takes to see a new patient, especially in our primary care clinics, because that's an important metric. We have a target of 10 days or less in all of our clinics on average to see a new patient. And some of our clinics are able to hit that, some are not. Well, then if they're not able to, we usually have a discussion, but a lot of times that's just a pure manpower issue. So we know we need to recruit either additional APPs or additional physicians for that particular clinic. Network utilization, also very important. And it's important not because we want to increase volume always. Of course, every hospital is generally looking for volume, but nowadays, this is a direct indicator of patient out-of-pocket expense. And so Being able to minimize patient out-of-pocket expense by keeping them in network is very, very important. And so we provide our primary care physicians and all of our referring physicians with network utilization information, so they have a general idea of where they're sending patients and how much of that as a percentage created an out-of-network charge for that patient. Because sometimes they just don't even know, like a referring physician, a primary care doctor, as an example, might not know that we have a specialist that takes care of a particular problem that they could ultimately refer a patient to and keep that patient in network. So a lot of times this drives physician education initiatives and various educational seminars to let them know the services that we provide. So I've grayed out the physicians here, but this is a real physician splitter report for a group of physicians that I was looking at about a week and a half ago because the data came out, and I like to look at this. Now you can see there are a lot of physicians that split across a lot of different hospitals, and I picked this particular physician grouping simply because there is a lot of variability as it relates to this, and a lot of them are who you would expect. The various THR hospitals, the medical city facilities, but we even have physicians that split with our own internal Baylor Scott & White facilities. So if you're not looking at this data, if your hospital president isn't seeing this data, it can be quite helpful and sometimes generates more questions than answers, but can be certainly worthwhile. So the database itself is super powerful, and it's super easy, in my opinion. If a president can do it, anybody ought to be able to sort and identify physicians that practice. And again, as I mentioned earlier, there's lots of different reasons why physicians split, but this can identify who you might want to have a conversation with to find out why they're splitting. And I've been amazed when I've had those conversations as to some things that have come up that I never even would have dreamed about would have been issues or opportunities for us to potentially correct. And regardless of whether you move market share, even if a physician continues to split at the exact same level that they're splitting, you can still identify information that makes your hospital better. That's why I find this very, very valuable, is for the improvement alone. So market trends. This is probably my favorite, and my next example that I'll show you is definitely one of my favorites. So anything related to market share in general and growth in general, are you increasing or decreasing in certain markets or in certain service lines? So that's very important. So the service line metrics are really important because that helps us determine for the populations that we're serving. And a lot of times we'll look at zip code data very specifically to determine if we're meeting the needs of populations. If local zip codes are going somewhere else for care, that is an indication that local zip codes and the people that live in those zip codes either don't know that a service is provided, or it truly is not provided. And it may be an opportunity for an individual facility to recruit a specific specialist or develop a specific service line. Lots of opportunity to look at payer mix shifts and just shifts in general. Is your Medicare volume increasing or decreasing? Is your managed care volume increasing or decreasing? One of the things we've certainly seen, for example, throughout the pandemic is an increase in the exchange plans. It used to be that we only saw about 1 or 2% of our population having exchange plans. A lot of months now that has moved to nearly 5%. So when you look at the sheer numbers of patients that is related to, going from 1% to 5% doesn't sound like a lot, but it is. It's a lot of patients. Lots of opportunities to look at services that you provide, whether, if you've got a service that you're providing and it's on a downward trend, you need to start asking questions about that. Is it because of the level of service that we provide? Is it because a particular physician that was practicing here moved out of the market? Is it because there's less demand? Is it because there's a hospital locally or even regionally that's providing better service? Lots and lots of questions that can raise as it relates to various market opportunities. And then again, service line shifts. One of the things, And if your hospital hasn't experienced this, I'd be amazed. But services that most people believe would always be hospital-based are moving out of the hospital. And Medicare is in the process now of revising their ambulatory list, and they have and historically have had an in-hospital only list. But complex spine surgery, even craniotomies now are being done in surgical hospitals, outpatient facilities. And so there are a lot of interesting market trends that you can identify by looking at this data to determine, for example, if I want to grow my orthopedic volume, my competitor isn't likely the hospital across the street. It's probably an ambulatory surgery center or 10 that are in the area. And if I'm going to try to grow that service line, that's my competition. And so knowing that can be very, very helpful. So let's look at how to apply market data specific to a strategy. So this is a true story, and I credit the DFW Hospital Council database solely for the success that the story will outline. It's really kind of a funny story in a way. But when I got here to All Saints, there was a surgeon that I hadn't met because I had managed cardiovascular services for the system. I had met this surgeon, and he was coming over here one day every other week, so twice a month, to see if he could drum up business as it relates to bypass surgery. And this was a highly gifted surgeon. Pretty much any kind of surgery he could possibly do. I knew a lot of the surgery he could do. I didn't know the extent of his capabilities. But when I got here, in a 7-month period, he did 5 surgeries. Now, again, he was only coming over twice a week, but during those 2 days that he was here, twice a month, during those 2 days he was here, he was really beating the bushes, going out meeting with all the cardiologists, saying, hey, I'm here, I can do this surgery, blah, blah, blah. Well, that wasn't an effective strategy. In fact, it was a terrible strategy because we have a lot of surgeons in Fort Worth that do bypass surgery. So one day he and I were having lunch, and I was just generally asking him how things were going. And he said, not well, I've just been very frustrating. I've been here a couple of years now and just haven't seemed to been able to move the needle. And I said, it's funny you say that because I want to hire a valve surgeon, a surgeon that does solely valve surgery, because there is no one really in the Fort Worth market that is doing valve surgery, especially complex valve surgery, valve repair, that kind of thing. All of the volume is either going to Plano or to Dallas or to the Heart Hospital or the Heart Institute in Houston. And he just kind of looked at me, and I'll never forget this. We were sitting at a table having lunch, and he pushed back from his chair and he goes, Mike, I do valve surgery. And I said, what do you mean? And he's like, I love valve surgery. That's my favorite type of valve surgery. I love the complexity of valve surgery. I'm like, well, you don't do it here. Like, why are you chasing bypass surgery if you're a valve surgeon? And he's like, well, I just didn't realize there was an opportunity. So he and I sat down and went through the DFW Hospital Council database. And we even looked at a lot of where patients were going that were in Midland, Odessa, and Lubbock, and Amarillo. All of those zip codes were all going to Dallas or Houston, mostly Houston, believe it or not. About half the volume that came to the, potentially could come to the Metroplex was going to Houston. The other half was going to Dallas or Plano. And I said, okay, here's what you need to do. Next time you get a bypass referral from a cardiologist, let them know that you're going to give it to one of the local bypass surgeons. But next time they have a valve, you'd like that bypass surgeon to potentially share it with you, or that cardiologist to potentially share it with you. So in the subsequent 6-month period, here's what his volume looked like. So not only did his bypass volume went up, because he got very quickly a reputation as a complex cardiac surgeon, not just a bypass surgeon. Not that I can't do bypass surgery, and I have a deep respect for anyone that can. But he did all the valves, all the complex valves, and he ended up in that following 6-month period doing 47 surgeries. And the majority were valves, but his bypass surgery volume went up simply because he got a reputation for being known as doing complex surgery. And so a lot of the complex bypass surgery that was going to Dallas and Plano ended up coming here. Now we have 6 full-time surgeons. So we went from 1 coming 2 days a month to 6 full-time surgeons now, including complex vascular, similar problem in complex vascular in Fort Worth. And so really the only difference was strategy, and that was solely based on data. So really kind of a fun story and a huge success. This can be applied to many, 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 many other service lines, and we've successfully done that as well. So now finishing up, let's talk about what's not important, because I think as analysts, as leaders that are able to develop dashboards that are meaningful, I think it's also important to know what's not meaningful. This is for me. This isn't 100% true 100% of the time, but generally speaking, the majority of the time, it's true. So data that is not fact-based or has errors drives me insane. So a lot of times you can tell this because you'll look at data and you're like, I just don't think that's right. Like, that just doesn't make sense to me. So how can this be true? And that's when I'll send the analysts back to the drawing board and say, hey, something's wrong with this data. You need to poke holes in it because it just doesn't make sense. And we'll talk a little bit of how to rectify that on the next slide. Upstream metrics that don't mean downstream results. I like, as you could probably tell from my examples, outcome data, because outcome data for me tells me if I'm doing well getting to where I want to go. If I'm not doing well getting to where I want to go, then I want to dive deeper in some of the upstream metrics. But there are lots of examples of this. Marketing always has upstream metrics. So clicks on a web page means nothing to me. I mean, it's great. And if you're in marketing and I've offended you, I apologize. But I don't really care about that. I want to know how many people versus last quarter are coming to us for esophagectomies or some new service line that we rolled out. Because to me, that's what's important, not how many clicks we got on our esophagectomy webpage. So that's just an example of things that aren't always important to me. Anything that's out of context. So yes, I monitor pharmaceutical expenditures, and I probably know more than most hospital presidents about pharmaceutical expenditures because I'm a pharmacist, but high drug costs aren't always bad. If you're getting reimbursed for that particular medication, for example, we have a very busy outpatient infusion center here for chemotherapy and other high cost drugs. I just cleave that out of our drug costs because we generally are getting reimbursed for those, and that reimbursement is good. So we actually do a separate financial analysis. So if you're just going to roll up drug costs to me and look at that, it doesn't really tell me anything because it's out of context as to whether we're getting reimbursed for that or not. Anything that's old or that no longer reflects the market or the current situation, certainly with COVID and the impact it's had on a lot of hospitals, that has made a lot of data really messed up. We fortunately did not have to cancel a lot of surgeries during this last surge, but we were only one of the only hospitals in the area that did not have to at least flex surgical volume. And that has created some interesting dynamics as it relates to data. So you need to take that in context. Another old database that is useful for some things, but not a lot of things, is THCIC data. Not bad. I'm not saying that that database is worthless, but it's definitely not as valuable to me as the DFW Hospital Council database because the DFW Hospital Council database reflects more current behavior. Anything that's incomplete or raises more questions than answers. Now, this one I say with just a grain of salt because I don't mind getting a dashboard that forces me to think more deeply about something and ask a lot of questions. But when data is incomplete because it's not clear to me what it's telling me, and I have to send that analyst back to the drawing board and say, hey, I get that you're telling me this, but I don't even understand what you're telling me, and I need this and this and this and this, and we kind of go through all the things. That is what is helpful for me. And then ultimately anything I don't need. You got to be asking your leadership and the folks that you're developing information for, what is it that you need? And the worst thing, and I had an analyst, he has since moved to a different state, but he 4 or 5 times would create a dashboard, and I would sit there and look at it and like, you know what, this is beautiful. And it has a lot of information on it, but there's not a single thing on this dashboard that I find valuable to me. And that's a really hard message to deliver to someone after they spend an inordinate amount of time developing something. Now, that data may be valuable to somebody else. I wasn't saying it was useless data, but to me as a hospital president, it wasn't valuable at all. So finishing up here, let's talk about tips and tricks for success. Again, if you just remember one thing, this is really the slide to remember. Always ask questions. To me, these 4 are the most important. So for specifically, what is important to you in your role, in my role? How soon do you need the data? How often do you need the data? Is this daily, monthly, weekly, annually? That'll save you a lot of time. Don't produce a daily report for me if I only need to see it every quarter. That is going to waste 90 days of data collection for you that you don't really need. And then what level of detail? Also very important. Do I need high level information related to this particular metric, or way more in the weeds kind of data? Next, always do a straw man. Just run a sample data set with a sample presentation format. Run it by whoever you're making it for and ask them, am I on the right track with this? Make sure they understand in the beginning. I don't want you to share this with anybody. This is just a total rough draft, but it will save you an inordinate amount of time and tell you if you're headed in the wrong direction, or more importantly, if like, okay, this is ridiculously valuable. Here's how I'd modify it a little bit to make it even more valuable. Make sure you validate the numbers, and you can do this in a lot of different ways. So for example, if you're using the DFW Hospital Council database for market share, bump it up against THCIC or some of the other databases that are out there to make sure that your market share data and the way you're pulling it and the types of things that you're pulling are correct and accurate. Because the worst thing you could do is make a decision on invalid data. That's totally true in war, but it's true in a hospital as well. So you always want to make sure that you have accurate data. So use outside statistics if you can to make sure that it makes sense. Ensure that you've got the right audience. So this is something that has driven me crazy a handful of times in my career. Someone somewhere in the organization will create a database and then they present it at a big meeting. And most commonly for me, it'll be at like a president's meeting every week. All of the presidents get together usually for about 30 minutes to talk about what's going on in the organization, what we need to be paying attention to. Very, very helpful meeting. Occasionally we'll have a guest that will present a dashboard, and we all look at that and say, that is the dumbest dashboard we've ever seen, or that dashboard is totally incorrect. Here's 50 things that's wrong with that dashboard. That person should have at least pinged 1 or 2 individual presidents to say, hey, I'm working on this. Does this make sense to you? Poke holes in it. Tell me what's not working and what doesn't make sense, and then go to the big group and present it. And that way you don't look like a fool in front of a large group of people. You actually look like someone that's trying to improve something in front of a small group of people. And last, always, always, always refine your databases. So really, no dashboard is ever perfect. There's always opportunities for improvement. It's kind of like the HR one that I showed you. I don't even know how many refinements that's gone through. It gets better and better all the time. Almost every month that we look at it, there's an enhancement. So yes, there are some you could rest on for quite some time, but I would always be looking at opportunities for improvement. So hopefully this was helpful. This is something that at least some of the things that I've talked about here can be helpful to you as it relates to dashboards, effective dashboards, and more importantly, effective data analysis. So any questions for me before I turn it back to Teresa and then to Mary?
Great job, Mike. I really enjoyed that. Like that, you brought up that you should, contact the CEOs before you go present to a whole group of them and have some holes poked at your dashboards before you get up there and you have a whole room of them poking holes at your dashboards.
Yeah, that can be painful for sure. Having experienced it, that can be definitely painful.
Yeah, we've had a couple presentations happen like that when they've come to our NTHIC and presented something and it didn't quite go as well as they thought it would. So anyways, so we do have a question over here. It says, what's your definition of real time? And in addition to outcome dashboards, do you have special teams or automated tools set up to help maintain your real-time data?
Boy, real time obviously is ideally immediately after something happens, but I really think it's the data that you're looking at. Like I mentioned earlier, if we're talking an infection or a fall, real time to me is same day. And I want that same day so we can dissect why a fall occurred. Was it because we weren't following precautions? Was it because a family member was helping the patient? There's a million different reasons why a patient might fall in your hospital. So real time, a lot of times generally is as close to the event as possible. However, if you're looking at things like market share and some of the other more trending kind of things, knowing real-time data isn't necessarily as important because I don't need to know that every day. I need to know it every month, every quarter, simply because knowing it every day, that could just be the weather. It could be a million different things that would modify volume on a day-to-day basis. And the second part of that question, Teresa, was?
Do you have special teams or automated tools set up to help maintain your real-time data?
Yes. And so we've got a lot of tools. We use Epic like a lot of other hospitals in the Metroplex. Epic has some really handy analytics and reports that you can use. I'm in Epic almost every day, always every week, looking at some of the dashboards that we've created within Epic that are populated truly real time. So COVID statistics, other things like that are literally as soon as we get a positive test back, that person appears on the dashboard. So yes, we do have not only in our electronic health record, but in some other tools, a lot of real-time data that we monitor. Great question.
We have another thank you that was very insightful. And then we have another question. Excuse me. Choking over here. What question that says, what team of analysts put together your dashboards? Quality, system, finance, all of the above? Is there a centralized team?
Unfortunately, it's all of the above. We do have a centralized team that does a lot of market analysis, and I work with them on a regular basis. They have access to databases that I couldn't even necessarily name to you that talk about, case adjusted growth rates and all kinds of other things that can tell how the Fort Worth market is moving from a population perspective, but also from a healthcare and a payer perspective, that kind of thing. But then also lots of local people that help drive individual analytics. We've got a couple of financial analysts, for example, that actually sit here in administration. They produce a lot of reports for us, like our daily length of stay summary report comes out. And I can tell you every day, every morning, like today, our observed versus expected length of stay right now is running 0.8517. That's what it was this morning when our analysts pushed that data out. It's pretty much an automated report, but then we can dive deeper into that analysis to learn, are there specific units where we're not performing well, others where we are? Sometimes that's a hospitalist issue and a discharge facilitation issue. So unfortunately, the answer for us is a little of both. We've got local folks, a couple of regional folks, and then certainly some system folks that are driving dashboard development for us.
Great. I don't see any more questions. Oh, there's another one. What practice do you have in place to ensure data integrity?
That's a hard one. And there are reports that come out that I know have limited integrity. And as long as I know what those limits are, that's important. For example, there's a dashboard that comes out that shows COVID numbers by hospital across the system based on Epic. Epic is not perfect as it relates to tallying COVID positive patients in a hospital. For example, I mentioned that we get a lot of transfers from other hospitals. If that patient had a COVID test in a hospital that was not an Epic hospital and that test doesn't flow across into Epic, then Epic doesn't view them as COVID positive until someone manually goes in and enters that data. And so that report always underreports COVID numbers. As long as I generally know it's plus or minus 5%, plus or minus 10%, I can live with it if I know the level of accuracy of that test. So we try to determine what that is as best as we possibly can for any of the dashboards that we create. Is it 100% accurate? Is it 90% accurate? If it's much less than 90% accurate, it becomes less and less valuable. Very good question.
Great. Are there any other questions? I'm reading the questions over here. I don't think we have anything. I think those were great questions.
Yes, indeed.
Yeah. So thank you, Mike, for your time today. We really appreciate it. It was a great presentation, and we look forward to maybe having you come present again. Who knows?
Absolutely. Thanks, everybody. Have a great conference, and certainly appreciate being a small part of it. Thank you.
Thank you. Okay, with that being said, we're going to move on to our next speaker, which is Dr. Mary Tietze. And I have known Mary. We used to actually be office mates. She worked here at the foundation, and so I've known her for quite a few years now. I'm not going to age us too much by saying the number. But Dr. Mary Tietze is a foundation alumni. During her stint here at the foundation, she was in charge of our rural grant and bringing on all 80 rural hospitals and creating analytics for them. And she's was very innovative in getting us the first dashboards that we ever had. Dr. Mary Tietze is a Myrna Pickard Endowed Professor at UTA. She previously worked at Texas Women's University as a professor, where she helped implement a nursing informatics program. She is all about informatics, nursing informatics. And currently, she serves on the TNA Health IT Task Force. And she has many years of experience in healthcare doing research. And she also does that for on consulting in addition to what she's doing at UTA. So I'd like to welcome Mary and let her present on an ecosystem for health equity and community improvement. 1 + 1 = 3. And she's just going to talk about interdisciplinary processes. So Mary, I'm going to invite you onto the stage.
Okay, thank you for that great introduction. Before I get started, I want to say some thank yous to the people at the council and the foundation. Over the years, they have been very supportive in having this data summit. The students have great pleasure to be involved with them. Frequently, they have posters that are involved. The other thing that's great about this is that they, at the Dallas-Fort Worth Hospital Council and the foundation, allow for students to have experiences there through capstones and internships. So I'm talking about healthcare informatics students and clinical informatics students. So big shout out to Teresa and her team for having the summit, and to Jennifer Myth, and also to Patty for supporting the students in the program they have for the academic program. Today also, I'm going to be using the THCIC data, as Mike Sanborn said, and it is very useful for our students to use, and I'm thankful for the foundation for allowing us to use that and teach the student. It makes my job so much easier to be able to connect the dots of the data that is patient through healthcare services and what the outcomes are. So And I want to thanks Greg Shelton for teaching me everything I know and to keep me informed of and the system going and with the students. And Mike, what a great presentation. I want to make a point about the 10-minute wait you have in the clinics. It's worth for me to drive over to Fort Worth just to experience that. So I'm glad you continue to monitor that. Okay, so I'll bring up my slides here. The share button, there we go. Okay, tell me when you see the first slide, somebody.
Mary, I see it, but I'm still seeing your slides on the side.
Okay, so I push. So still seeing the one where the small slides are there?
Yes.
Okay. Let's see.
If this doesn't work, we can bring them up for you.
Okay, let me just try one more where I use that share.
We're all learning this new platform together.
Okay, so then if I do.
There we go.
Okay, it's one or the other. Okay, so again, as I said, I'm previously at TWU and currently at the UTA, and really one of my favorite topics is about the ecosystems of health equity and how you can involve the community. People that know me know that I've been involved with community activities for many years. I think that if you take, a provider, an analyst, and the patient's needs, and you can include the community, you end up with 1 + 1 = 3, actually much more than you would have individually. So thank you for letting me talk about this. Did my slide show? Okay.
I'm sorry, we're seeing your slides.
Compact care need. We have complex patients. What it means is we have the data now that actually can help us see how complex those patients are. Here's an example of Chris Arnade, who actually embedded with poverty patients that are citizens. We don't get to see poverty a lot and frequently, and to really drive home, what it's like for them. Here we have a woman who is, got children, probably without a job and so forth, but there and the children are there to be seen and be happy with what they have. The one in the middle, that's a family living out of their car. And then, of course, on the far right is a father who fought many times to keep his children under his own care. So he gets support, but again, that's the way that they want to live. So what Chris came out saying is that the theme that he gets from those people are, when you don't have anything, respect is all you have. And I think that we can keep that in mind as we continue to do the analysis for these folks. So my objectives for today are to describe an ecosystem live in. That's what I like to think of. That's what I like to teach the students about. I'll go into then the social determinants of health, SDOCH, and that is about things we've learned about recently, and actually more importantly, what we've learned through the pandemic. It really made it real crystal clear, the distinctions between what you have and what you don't, and your healthcare status. And then I'll illustrate a step-by-step approach to analyze in terms of health and outcomes, and then leave time for questions. So an ecosystem, it's a kind of a buzzword now in terms of assigning the complexity of all those that are involved. So, on the far right, you see that you have an image of it where you've got, the plants, then you've got the habitat that the plants are within, and then you've got the ecosystem, which is the environment, the minerals, and so forth. So we also have an ecosystem similar to that. That's a biological. If you look at the definitions here, community of interacting organisms and their physical environment. But there's also in general use, we're starting to use it as complex networks or interconnected systems. That you'll see that with some of the Silicon Valley's talking about their systems. And then in the far bottom, you have the ecosystem broken up into biological versus digital. And I'm going to focus primarily on the digital. Oh, okay. The 21st Century Cures Act is what has allowed us to have more services available now, and has moved along the use of data. So we have the push from that act that was in 2016 that said that we have research now in the act that shows you're supposed to remove barriers to any kind of research. We have getting treatment to patients more quickly. It's fostering coordination. So that the monies from the government and the messages from the government is to move things along, modernize your clinical trials and so forth, to include the app movement faster and use of the data. And then thirdly, it's about the Cures Act is about keeping jobs here at home. So it's ensuring a U.S. that remains global in leaders and in medical innovation. That is where, for my experience as a health informaticist or clinical informaticist, the government is putting a great deal of effort and funding to the workforce in the U.S. of becoming more public health informatics knowledgeable, so that when we have another pandemic, we are able to have our own analysis of it by our own people and actually act more quickly than we were able to this last time. So again, the 21st Century Cures Act talks about an ecosystem that would be needed for that. So like I said, the Cures Act, and then the second bullet, it acts to introduce provisions that push greater interoperability and adoption of electronic health records. On the right side, it also allows patients to have access to their data. Again, this is an ecosystem. Once more people have access to their own data and others have access to that data, the ecosystem is evolving. And then it's very similar to how banks have done in Europe. We need the healthcare app ecosystem to be moving along, and that's literally in the 21st Century Cures Act. Another thing that is in the ecosystem is interprofessional collaboration. The World Health Organization defines that as interprofessionals, multiple workers from different professions and backgrounds working together with families, carers, and communities. With our digital abilities now, we can actually connect each other better. Whether we actually do it or not is still something that's in the works. So there's an effort there to be more interprofessional and collaborative, to make 1 + 1 = 3. The bigger picture of that, and studies do show that when you do interprofessional interactions and for the patient, you improve patient care, reduce medical errors, you start treatment faster, you reduce inefficiencies and costs, and then you improve staff relationships and job satisfaction. So there's lots of good reasons to be focusing on the interprofessional nature in an ecosystem. Here's an example of community involvement by healthcare professionals by staff, your own staff, and your students. You should be encouraging them to participate in activities such as this one that was on June 5th this year at Baptist churches. And it was there, they needed lots of support, from me, from the students, to actually deliver some of these. And the whole objective was then to get the population in that particular zip code to be more involved with studies that are going on at the national level. So that was one example of how we can work 1 + 1 = 3. So now I'm going to move to the association of that ecosystem to social determinants of health. So in a definition of some components of social determinants of health, before I get started, are 4. And they are many times used interchangeably. I know there's experts of you out there that will attest to this and actually maybe have a better way of explaining it. So a disparity is that the quantity that separates a group from a reference point. The reference point is the one that's probably usually doing the best at it on a particular measure. And it's expressed in terms of a rate or a proportion. So I'll give you an example of a disparity. A disparity, for example, on infant mortality is something that's commonly known per 1,000 live births. So mother's education, becomes a disparity in terms of if you have an early education of 9 to 11 years, you're going to have a mortality rate of your infants of 5.1. If you have 16 or more years of education, your rate of mortality for the infants is 4.2. Doesn't seem like a lot of difference, but it's actually 122% difference in the two of those. And so that's a disparity as it goes to education. Inequity is the fair distribution of health determinants, outcomes, and resources within and between segments of a population, regardless of the social standing. So an example of inequity is, again, percentage of mothers with 12 or more years of education, by race. So we look at the distribution, and the not white, non-Hispanic mothers who have 12 years of education is 90%. And we go to the lower area of Hispanics, and again, could be cultural, but it's at 52%, half of that. So that's an inequity that is about a social component of their characteristics. Inequality is a measure of degree of association between differences in rates between groups. An example of an equality and the distribution of it in a population is among the white non-Hispanic mothers. The educational inequality that has been identified has actually improved and at an index of 7.3% over the course of the last 4 years. Take that same example and use it for mothers of Hispanics, and the rate of them having a 12 years of education is only increasing by 1.1%. So it's a difference of 7.3% movement in improvement to 1.1, which is a very slow improvement. That's an example of inequality of the measures. And then lastly is burden. Burden has to do with the persons that are affected between the groups. So again, with the infant mortality, the mothers that are 12 years of education are in the numbers of 6,000. And that is the infant deaths associated with those are in the number of 12,000. The mothers, and those are with mothers of 12 years of education. The comparison of that is that There are others in the 16 years of education that only have 3,000 deaths. And then there's others with 9 to 12, 11 years that are only at 3,000. So the ones that are in the 12 years are actually having the higher proportion and burden of the infant mortalities. So there's an example of each one. And a lot of times those are used interchangeably. Then there's the component of what part of the social determinants of health that we're talking about here. So one of the social determinants of health has to do with a neighborhood that you're in. I'm going to show all of them in just a minute. But of the neighborhood, we are monitoring how many are really improving over time. And if you look at the box to the right, there are three targeted or met outcomes that are. There are 0 that are really improving. There are 3 that have no or little detectable change. And there's some that are getting worse, and then none that are getting worse, and then 16 are staying at the baseline. Okay, so then I'll show you what those details are, but these social determinants of health are very vast and measurable through the communities and the gathering of the information from researchers and the federal government. So again, on the far right, what you see is all the buckets of the social determinants. I think many of you might be familiar with this. It's going to be your healthcare access to and quality of your healthcare. Community context and how the areas in your community function with each other, and then also the environmental components. Then there's the economic stability or the poverty component of the social determinants of health that are associated with a particular population. And then, like I just given you, the education as examples of the disparities and inequities and so forth, and what that does to infant mortality rates. Okay, so in the environmental component, the ones that are being measured are what's the violent crime rates? Also, do they have broadband internet? And to what degree do they have it? These affect social determinants of health. Environmental health, what level of toxic pollutants are there in the air that they're in? Healthcare policy, what is the water system as policies have dictated should be in that particular area? Housing and homes, how much lead levels are in the children and those that are living in that area. That tells you a little bit about the housing. Injury prevention, again, motorcycle accidents, motor vehicle accidents that are happening, and the crash deaths associated with those. People with disparities, those with disparities that don't have steps, that have steps and no ramps to get into their housing. Physical activity, how much walking or biking can happen in that particular zip code or area if you don't have sidewalks, or if your streets are not paved. Okay, so there you have the inequity of being able to walk or bike. Respiratory diseases such as asthma, what level of asthma is occurring. Sensory disorders like hearing loss because of loud noises in the environment that are ongoing. And then tobacco use regarding smoking, and then transportation, a big one. Do buses go there? If so, how often? And can they take the participants, the population, to their physician's clinic for their visits? Okay, so again, we're learning a lot more about the complexity of where people live and how that affects their ability to be healthy. So in the social determinants, the skills are to support the awareness of that. That's what we're trying to get to the workforce. We want to incorporate them in curriculum, which is what we're doing in most of the health informatics and clinical informatics content that's being taught. the point there here is where the ecosystem comes into place, because you need to strengthen interdisciplinary collaboration with social work, with public health, with city planning, with occupational health, your police, your firefighters, to ensure that care is delivered effectively in the community level. We need to be teaching that at the curricular level, and also actualizing that in our day-to-day work as healthcare delivery professionals. So it needs to be included in administrative policies. Stay current on the proposed legislations relating to social determinants of health. Advocate for the use of these documentation tools so that you can track that, and then integrate the social determinants into assessment of the electronic health record. That needs to happen too. So it's just like any other code that you're tracking. An example of what the federal government wants to do about social determinants and the ecosystem is the All of Us research workbench. That's a study that has been going on for about 5 years now. We're trying to get 1 million participants in the minorities and underserved. We don't know enough about these folks in our current research. So we're actually trying to get, we're teaching that in the curriculum, and we're also then teaching the researchers how to mine the workbench that's being created. That includes the blood that has been collected from those, which is your genomics, through the saliva, through the urine, and then all the physical metrics that go along with those that are in the study. And there's the numbers that you see of what we've accomplished so far. An ecosystem, trying to get everybody into it. The other thing, policy-wise, is the Gravity Project. The Gravity Project is a process where we're actually defining what the social determinants of health ICD-10 codes will be. All right, we have them for asthma and heart failure, and some of the things that even that Mike had on his dashboards, but we don't have them yet for educational level, what zip code, what issues are associated with not having fresh food, or having the area that you can actually do some walking. Those will become ICD-10 codes. So this is a group that's been funded, and they're looking to the third, fourth bullet. They seek to identify coding elements and value that creates a value set to represent the social determinants in health, along with all the other diagnoses that we have. It'll focus right now on food insecurity, the ones that, and then housing instability and transportation access. So those were prioritized out of that wheel that I had showed you, out of all the social determinants. So that's happening as we speak. So an illustration of a step-by-step approach to analyzing this information as we have it today. Again, I mentioned that we use the THCIC data for a lot of, just for teaching, and that's what I've used today. But the prerequisite to an appropriate analysis is reliable data. Very much how Mike has emphasized that, and our speakers yesterday, John Bowe and John Bauer, who are our data governance presentation, and how important that the data stewards are, to making the data actually be accurate to be used. So the data quality matters. There are government agencies that are able to provide that. National research organizations are good sources for that. Private market research organizations, and again, they will probably have their examples and their stamp of approval for data and abilities to demonstrate that if we look at them. And universities. Now, I'm not saying that universities have all accurate data, but they are a source where there is a lot of data being collected. So those should be included too in terms of when you're looking for. Then the databases that are ready, for us to be using are the ones that we pay for, our tax dollars at work, for the CDC, for the U.S. Census Bureau and Human Services, and then other local agencies such as the Texas Healthcare Information Collection Database. So there's 3 main steps to getting complex care analyzed. First, you want your data to be able to compare groups. I know these are small. We'll be showing you a little bit more later. But to be able, this particular left on number 1 about comparing groups, it has all the different races in there. So it's got Asian, it's got Hispanic, it's got the other, it's got 2 or more races. So very detailed analysis of the races and what they're living, that are living below poverty. Okay. Number 2, explore the correlations. You have to be able to show what variables affect what variables. Okay. And so in this case, we have mental diseases, mental disorders. And you're looking at that in terms of the median economic household, median household income. So, as you can see, has the higher on the far right, the income becomes of a household, the less frequent medical distress occurs and disorders. That's a trend. That's a relationship. And then you have to be able to also show the trend over time, and so that you get a full picture of what's going up in terms of improvement or going down. And here's an example of using the the races in terms of Black, Hispanic, white, and overall, and what the trends are in live births. So as you can see, the Black population has more of the live births, and their trend is coming down in terms of those, and these are for females that are between 15 and 19 years of age. This has to do with teenage pregnancy. And so there is improvement, and we want to see that over time and by race distribution. But don't forget that all the work that goes along with this data involve and should involve a solution to this relating to the community. So connect with the community in terms of these metrics. Connect with social media. It's another way to get some of this information. Citizen science, where the citizens can actually put the information in on their own databases and to be mined, and crowdsourcing are also coming up. And then not forgetting that there's a connection with academia, and that's your pipeline. Academia is the people coming down the pike who are going to be the health informaticists and the clinical informaticists who carry on the baton going forward for all this work. We have the data source that I used was the THCIC. This is the main web page for them, the outpatient data set. Okay, so as you can see, we are fortunate, very fortunate in Texas to be one of about the 35 states that actually mandates that claims for every patient who's been in a clinic or hospital sent to the Department of Health, and they have been the warehouse for us to utilize. And Teresa and her team and the Dallas-Fort Worth Health Council Foundation manage that data as well for North Texas. And again, the acronym Texas Healthcare Information Collection, THCIC. So again, it was evolved out of a safety code, section 108, where the council will legislatively indicated that the data will be mandated and required. If there'll be penalties, for not providing that data. And luckily, we also not only have an inpatient public use data file, but now an outpatient data file, and it also includes emergency department services. So a vast amount of data that can be analyzed. And I know many of you already know this, but for us in academia, we have the THCIC data set through the Dallas-Fort Worth Hospital Council. So this is how when I pull the data using ClickView and the THCIC data that's available, the fields that mattered are exampled here in terms of the quarter of the data. These were filtered on patients with diabetes as their diagnosis. And it was for diabetes 1 and diabetes 2, okay? And so that's the filter here on the outpatient basis. It shows how they were admitted to the clinic, what the discharge status was, their age groups, what gender they are and sex, what race they are, ethnicity, as you can see down on the bottom, county, zip code, what payer is associated with the patient, and then the diagnoses, length of stay, total charges for the services, and what mortality. Okay, So also another source that I used for this was the Social Needs Index that is available on the healthyintexas.org. Another thing that I'm very fortunate about that the North Texas area makes available for free to us, to mine, to anybody, to look at these community-based data that are available through the work of the Healthy North Texas and Conduit, their vendor that provides the data. So I looked at that, and of that data, it involves the index. Now look to the right. An index is calculated for social needs based on poverty level, and this is at the zip code level. I'm talking about, but also can be at the lower than that. Income, unemployment level, occupation, what the occupation is, the educational level, of course, and this one included language. Is there how much English speaking versus English second language is in the area? And the indicators were weighted based on two things. On the far bottom, it says where the nature that they had to do with reflecting on premature deaths. So again, remember I talked about relationships and associations, and then the other one on what were preventable hospitalization rates. Okay, so that now we have just a number that's taking care of all this analysis for me. And I was able to pull that number for the North Texas area. So by zip code, again, the higher number are the higher needs. So it goes from 1 to 100. Okay, and then there's different rankings, but the number that matters to me is the index itself. So zip code 75210 is at the highest social needs based on what I just defined about the index. And then you can do a geomap, of that in terms of where the highest level of zip codes are. And I'm showing that a little bit more. This is an actual in terms of the data of 2019. And what I did was I appended social needs zip code that was there associated with the social needs index for those patients with diabetes 1 and diabetes 2. Okay, so I have that information and I appended it to the zip code of the case or the patient that we have. Okay, so now I know not only about the patient zip code where they live, but the characteristics of that zip code. What we're able to then see is I said about how many zip code, how many of the patients in there, that zip code, have diabetes. So I did a multiplication or a sum of the number of patients in a particular zip code and the index that goes along with that to get the combination of the zip code with the index. And here we have a zip code of 75228 that had, this is about total charges. How much services are associated with that particular zip code? So if you're going to prioritize something and where you want to associate care, these are using the most care and services based on the clinics that we're pulling the data from. And those are the top 9 that we want to focus on. So should we also stratify? You should also stratify by race, gender, and primary payer. And so you can add those elements to this particular analysis to give you a little bit more information about what your approach might need to be to associate this. Now, another way to look at this is to see the degree of the total charges as a proxy for the delivery amount and the intensity. So we have it here, the larger size is going to be the degree of the number of index and the patient's cost. So there's your cost in the upper left of $800,000 for 75 patients in the zip code of 75228. So it's not a very highly populated one, but it is costly. The 75150, which is the darker purple, had 9 in it. That again, these are patients with diabetes, and the cost was less, but they had the higher count. So this gives you, 2 dimensions at once. And I use Tableau to, as I took Excel into Tableau to do this analysis. And then, I'm a little freaked out after having Mike Sanborn talk about dashboards, but I easily created a dashboard with the 4 different cuts of data that I was looking at, so it can be seen all at once. And then it can be interactive as well. And again, these are patients with diabetes, type 1 and type 2. A lot of further analysis can be done. So we're taking the social needs index with the patient count, and then associate that with the total charges to be a proxy for the services rendered, is a way to look at this information and what you might want to do with it. So teaching and learning, we want to do is all healthcare professionals be able to be aware of the roles they have in healthcare equity and to improve that. Here are some of the roles. Again, armed with this data and understanding of the data, you can be a care coordinator towards that effort. You can be policymaker, clinician awareness there, advocate for this social determinants of health and the needs, educator, such as me, pushing that through our curriculum in the universities, researcher, scientist, getting down at the detail of what is actually affecting, how much race is involved, what is the difference in the gender, for example, and ages of an education, deep dive, and then administrators, just to be like Mike, for example, saying we're understanding in his catchment area where his patients are coming into the organization, understanding of what the characteristics are for social determinants of health. And then informaticists, again, like myself and others, much better than myself. I'm a baby informaticist compared to some of the complex informatics that are going on in public health now, but we do want to get the workforce coming down the pipeline, able to keep up with the data that we're generating out of these EHRs and elsewhere, and make some information and wisdom out of it. That's what you want to do with data. So I'm hoping that in the time today that I've had with you, I've been able to describe an ecosystem for you to get an idea, associate social determinants of health with that ecosystem and how it would work. If you keep in mind, and I try to get the students to keep in mind that you are in an ecosystem, you're not in a silo, then you reach out more to other opportunities that you may have for care of the patient. Number 3, I hope that I illustrated a step-by-step approach to the analysis of how you would use, for example, a socioeconomic index, as long as you have a zip code to append and connect to. Now you know about the patients in that zip code and the zip code characteristics itself. And with that being said, I will be available for questions, but my contact information there, and just a reminder, all together, we can make 1 + 1 = 3. And we need to do that for those that need it. Teresa?
Great job. Thank you so much. I think it's important as those working in data analysis and data analytics and in healthcare, trying to figure out how we can, improve health care and the community health and things like that, that we work with multiple partners and we don't just think, well, how do we do it here in the hospital? Reaching out and getting more of the community involved in how we, take care of these patients so that they're, not using the emergency room like the doctor's office and those types of things. So great job. We do already have a question. So if you have a question, please put it over here in the Q&A. And this is from Tietze, and she says, how do you access free collaborative data? So I don't know. I mean, I know you have ways that you're doing it.
Data is a lot of what I had on the slides in terms of the Bureau of Census that has a lot of characteristics about each zip code, where you get the educational levels, that employment levels, where you get the income levels. So that those sources that are on that particular slide, and of course there will be you'll be getting this as being part of this. The other thing is actually some indexes that are available, like the one that I showed. There are several kind like that are free. I didn't pay much except for getting access to THCIC. Now again, if you're in Texas, that's a good data set to be familiar with. And there are ways to get to that as well. Maybe not all free, but if you're in a state institution like the universities, we get it for free. They want us to mine THCIC, which is what we do, and we teach it. And thanks to Teresa and Jen Miff, we don't have to take the flat file and make anything out of it. We can use a business intelligence tool to access it. So I guess it's a matter of just being aware of the massive amounts of Centers for Medicaid and Medicaid Services has a lot of free databases on chronic conditions and that you can look at too. So I don't know if that answered the question, but I'd be glad to talk offline for more of those.
And, Medicaid, that's mostly here in Texas going to be, pregnant moms and children. For the most part, that's not true of every Medicaid patient. But there is a lot of that if you're looking. I know I just happen to know Cetha works for March Dime. So, there's going to be a lot of infant information in the Medicaid data.
Can I just remind everyone too that the All of Us research workbench is available to anybody. That's got the genetics in it. That's got the minorities in it. So they want us to mine it. So they're making that available. So go to www.allofus.nih.org and you will have vast amounts of information about that.
That's great. And I also want to bring up the Z code thing because we had a presentation talking at the end. She brought up the Z codes, and there are a lot of Z codes out there now for social determinants of health. So while I have, this platform, I want to remind everyone we're going to be looking at how much that's being coded because, that is a way to be able to capture some of this information. And what we've heard from the hospitals is it's something that has to be documented before it can be coded. So it's a big, huge process to change, whether that's a discharge nurse or someone, the physician, who's going to document that and record it. So there's a lot of work there to be done, but any help that this group could participate in helping get that done, how we could, work on getting Z codes in the data would be really great. So,
and then keeping up with the Gravity Project that I have in the slides, because they're kind of the front runner of how this is happening.
So did we have any other questions? You had perfect timing, Mary. Thank you so much. Great presentation, reminding us that, we're not all alone. We need to work together. And we appreciate your time today.
You're welcome. Thanks for having me.
With that being said, we're going to take, I think we have a 10-minute break scheduled. So you can take care of some business really quick or network. Go check out our vendors, who have been our sponsors, and also the posters to get enrolled in the raffle. So 10 minutes, and then at 11:05, we will be meeting, have Mary Ann Contreras coming on the stage to present from JPS about a real unique project they've had going on in data collection and identifying abused patients or sex trafficked patients. So that's going to be really interesting to hear from Mary Ann. And that will be the end of our day. So Kevin, if you'll put us in a 10-minute break, and then we'll be back.